Hello, my name is Dermot Ryan. I'm a general practitioner from the UK with a long-term interest in asthma and in allergy. Today we're going to discuss a child with persistent upper airways symptoms. Now, rhinitis is a highly prevalent condition affecting all age groups across the world. It significantly impairs the lives of people with rhinitis, including the people who live with them. Underdiagnosis and misdiagnosis are both common, which leads to under or inappropriate treatment, with accompanying economic impact and potential harm to the patient. Most people with rhinitis manage the condition episodically, either with self-management or over-the-counter medications purchased from the pharmacy. However, many underestimate and neglect their symptoms and often do not bring this to the attention of their GP. As this is a common problem, and it causes frequent comorbidity affecting the management of other conditions, it needs to be recognised and managed appropriately in primary care. Today we'll use the case of Liam to illustrate some of these circumstances. So Liam is a 7-year-old lad who loves playing football and playing around outside with his friends all hours of the day. He has had symptoms of nasal running and blocking with sneezing for a couple of years. His parents don't like to trouble the doctor and have used over-the-counter remedies to help Liam with his symptoms over the last couple of years. Unfortunately, these remedies don't seem to be working anymore. So the learning objectives today are to understand the negative impact of allergic rhinitis on children, to distinguish between some of the treatment obstacles of allergic rhinitis, and identify the potential use of allergen immunotherapy for allergic rhinitis. Back to Liam. What are the reasons for bringing him to see the doctor today? His parents have noticed that since the middle of May there's been a marked decline in Liam's energy levels. He doesn't appear to be sleeping well, and Mum and Dad have also noticed that they can hear him snore sometimes. At the parent-teacher evening, the teacher complains that Liam has become inattentive in class and doesn't appear to hear what is being said to him, and furthermore, his academic performance appears to be dropping. The parents have noticed he's also coughing quite a bit. Taking a medical history, very importantly, his mother has been purchasing over-the-counter antihistamines for him, but they're not sure that he takes them. 7-year-olds really do need to be supervised when taking their medication. Mum herself had eczema and hay fever as a child. They live on the edge of town with fields opposite the house. Neither parent smokes. They have noticed that although Liam has mild symptoms throughout the year, that these have been much worse over the last few weeks. He doesn't seem to have the energy to play football anymore and generally appears lethargic. Mum has also noticed he's coughing more. On examination today, Liam looks thoroughly miserable. He has a transverse nasal crease and shadows around his eyes. His chest examination, however, is normal, and his peak flow reading exceeds the expected value by some 15%. On examination of the anterior part of his nose using a pen torch, the inferior turbinates are swollen and edematous, and there is a clear nasal discharge. Ear exam reveals that there is a bilateral secretory otitis media. So what do we think might be going on? Well, we suspect that he has seasonal on top of perennial allergic rhinitis and is accompanied by comorbid secretory otitis media. Clearly his sleep is also impaired, affecting his academic performance and energy levels. Liam agrees to having a blood test performed on him to aid the diagnosis, so a sample is taken off and sent for specific IgE to common aeroallergens. So you explained to Liam and his parents that Liam appears to have perennial allergic rhinitis, probably due to house dust mite, and now has seasonal allergic rhinitis, commonly known as hay fever, probably due to grass pollens. This is causing blockage of his nose, postnasal drip causing his cough, and fluid behind the eardrums leading to his reduced hearing. And altogether, this is also interfering with his sleep quality and affecting his get up and go. He's lost his energy. We also checked Liam's visual analog scale for rhinitis symptoms, and he scores 8. The VAS is a score ranging from 0 to 10. A score above 5 indicates moderate to severe disease, whereas 0 to 5 indicate mild disease. Blood tests are sent off for a specific IgE, and the importance of ruling out asthma completely as a cause of cough is shared, and Liam and his parents agreed to doing twice daily peak flow readings and to come back in a couple of weeks' time for review. We agreed together to use a topical nasal decongestant, but only for 5 days. The purpose of this is to reduce the nasal edema, to allow the topical nasal steroids to have their effect and benefit. This has to be used every 4 to 6 hours for those 4 or 5 days. After 4 or 5 days, the nose starts becoming accustomed to the medication, and you may get rebound blockage of the nose, so it should be limited to 5 days only. We agreed together to use nasal steroids. It is explained that nasal steroids are very safe. We also demonstrate how to use a nasal spray, in particular avoiding the central nasal septum. Liam is started on 1 puff of either fluticasone propionate, fluticasone furoate, or mometasone, whatever is available locally in your area. 1 squirt once a day. The advantage of these 3 topical nasal steroids is A, they have very low systemic bioavailability, and B, they only need to be taken once a day, improving adherence. The importance of taking the medication daily and as directed is emphasized. Having read the newspapers, parents ask about allergen immunotherapy, and I say we'll discuss this at the next visit when they come to see me in a couple of weeks' time. So, they come along in a couple of weeks' time, and at this review, Liam is looking so much happier and so much better. His parents now report that he's going out to play again with his mates, and that his energy levels have improved significantly. His peak flow readings reveal normal diurnal variability, suggesting that he does not have asthma, and his VAS score is down to 5. Blood tests suggest that he has a moderate titer to house dust mite and a high titer to grass pollen. They are negative for cat, dog and moles. A further conversation is had concerning AIT, especially sublingual immunotherapy or subcutaneous immunotherapy. At the end of this, the parents will understand the following about allergen immunotherapy: that it has better results in patients with moderate to severe symptoms. Most people with mild disease are adequately controlled with over-the-counter medication, so there's very little added benefit. It helps when, after using standard treatment, the patient is left with residual symptoms, despite avoidance measures and taking the medication regularly and correctly. We see that Liam is left with a score of 5, suggesting a considerable number of symptoms still remaining. That it's an excellent option if allergic rhinitis is interfering with his activities or with his sleep. You explain again that AIT comes in 2 main forms: subcutaneous immunotherapy and sublingual immunotherapy. Liam's parents have decided that they would like to see an allergist to discuss this more, and so a referral is made to an allergist.
Thank you very much, Dr. Demarraya, for sending me and referring me Liam with Liam parents to discuss about allergy immunotherapy. Good day, everyone. My name is Dr. Juan Trujillo. I'm a pediatric allergy consultant in Cork, in the Republic of Ireland. So Liam parents came to me because they're interested in allergy immunotherapy and have many questions. They have tried to read a lot of them from different search engines in the website, but instead of giving them more information, they have more headaches about what is the correct answer for their questions. These are the most important questions that they have. What type of allergy immunotherapy exists and how long is the treatment? Are there any side effects? And is this going to cure Liam's allergy? As you can see here, there is a map of the distribution of the prescriptions of allergy immunotherapy across the world in different regions in the future, and you can see that there's a good amount or an increased prescriptions in different areas and still not that common in other ones. Depending on the place that you are seeing this video, you're going to see that there's more options in your country or in your area for information about allergy immunotherapy. Let's talk about the first question. What type of allergy immunotherapy exists and how long is the treatment? There are two different types of the most common allergy immunotherapy for inhalants in the world. One of them is sublingual immunotherapy and the other one is subcutaneous immunotherapy. Both of them have been in research and clinical settings for many years, almost 20 to 30 years, the youngest one of them. Sublingual immunotherapy are used between tablets or drops that could be taken daily for 3 to 5 years, and subcutaneous immunotherapy is used as an injection that could be taken between 3, 4, or even 6 weeks, every 6 weeks, for also 3 to 5 years. Both of them with similar profiles in different areas, but with a strict difference in other ones. As you can see in this picture and this graphic, depending on the place that you live, again, there is a percentage of people that will be prescribed with more sublingual immunotherapy and other ones that will be prescribed with subcutaneous immunotherapy. That is something important because sometimes you're going to be in an area that they could decide between subcutaneous or sublingual immunotherapy depending on what is better profile for your kid. If we compare by efficacy, both of them has decent amount of efficacy. Safety-wise, sublingual immunotherapy is a little bit more safe than subcutaneous immunotherapy, allowing it to be taken daily in your house instead of being going to the hospital or going to the primary care center or going to a clinic to administer a subcutaneous immunotherapy. By convenience, sublingual immunotherapy could be taken home, you could go traveling and you could take it daily. By compliance, there is more compliance about having something subcutaneously once a month instead of taking one pill or one tablet or one drop daily. Cost, sublingual immunotherapy has a higher cost than subcutaneous immunotherapy, and the possibility of having multiple allergens in the same mixture for a sublingual is not that common, and in subcutaneous immunotherapy you could have different allergens mixed together to have subcutaneous treatment that way. The choice of this will be good and important information that you will need to decide with your specialist to see which one actually will be better for your kid, in this case Liam. One of the favorite questions that my patients have is, doctor, is there any side effects? And if there are any side effects, which one has a worse side effects, which one have more problems, etc. The usual way that I have to explain patients like Liam parents is that if you're doing the correct treatment and you know how to provide the correct treatment, the percentage of side effects that are bad are less problematic. Saying that, you will try to prevent those side effects to come, or at least you will explain it before they. From the point of view of subcutaneous immunotherapy, is more common local reactions after the first doses of subcutaneous immunotherapy. This could decrease depending on the amount of time that you're taking the allergen in subcutaneously, and usually after 1 to 3 months it will decrease the percentage of local reaction. You could prevent the local reaction with previously administered antihistamines, or not, that depends on the place that you're going to do it and the knowledge of the allergist or the specialist that is going to provide you with subcutaneous immunotherapy. There are some side effects that could become more problematic, especially if there are systemic reactions like anaphylaxis. And that's one of the reasons that is necessary that subcutaneous immunotherapy will be administered in places that are in primary care, in hospital base, or in any specialized allergy clinic that they have in other parts of the world. In the case of sublingual immunotherapy, the reactions are more localized to the area of peribuccal, of the lips and the tongue. There is less frequent episodes of anaphylaxis and in comparison to subcutaneous immunotherapy, and that allows you to use sublingual immunotherapy, as we say, at home daily without having many problems. You could start using antihistamine previous administration before the sublingual immunotherapy if you're having too many peribuccal symptoms, and it will also decrease with time after administering sublingual immunotherapy after a couple of months. Finally, the most important questions that they will ask me, and it's difficult for me to explain them sometimes, is this going to cure Liam's allergy? The correct answer will be no. This is not what we're looking for. What we're looking is for Liam to have a better quality of life. And allergen immunotherapy decreases the symptoms, and better, if the symptoms were moderate to severe, they will decrease it for mild symptoms in the majority of the patients, increasing their quality of life and returning them to their normal lifestyle. That is what we are always looking for. How can we be sure that allergen immunotherapy is working better? We have to select the adequate allergen. Let's say, for example, that Liam has an allergy to grass pollen and house dust mite, but his symptoms of grass pollen are higher than house dust mite. If he uses a grass pollen immunotherapy, he will get better relief and have that decreased amount of symptoms. However, if he uses house dust mite and is not the most important allergen that we have to select, probably the symptoms are not going to get better, and that could decrease the adherence of the treatment. They are short and they are long-term relief in allergy immunotherapy. But from the allergy point of view, we're always looking for the long-term reliefs, showing that it could decrease the symptoms for many years. This will also help you modify the disease, saying that there is a cascade of allergy that we could block using allergy immunotherapy. So at the end of the day, what will you choose? Sublingual immunotherapy or subcutaneous immunotherapy? Let's go to the next slide. As we were talking before, there's no correct answer. Both immunotherapies are good. Both immunotherapies has evidence, and both immunotherapies are available depending on the place that you live. If you go to one place of the world, probably they are more prone to give you sublingual immunotherapy. But if you go to other areas, subcutaneous is also more available. What can we know about these two and which one to choose? First of all, let's summarize. Sublingual could be drops of tablets, and it goes under the tongue and you take it daily. Subcutaneous will be injections in the doctor's office, usually at the beginning, weekly, until you get a maintenance, and then you get monthly maintenance. Convenience. Sublingual is very convenient. You don't need to go to office visits. Subcutaneous is less convenient. It requires regular clinic visits. Safety. Sublingual has a lower risk of severe allergic reactions, which allow us to do it at home. Subcutaneous has a higher risk of systemic reactions, which actually ask us to do it monitoring after each injection. Effectiveness, both of them are very effective. Sublingual may be slightly less robust in some allergens, and subcutaneous more effective across a wide range of allergens. The onset of benefit. There is a gradual improvement in both of them, so there is no difference there. In the cost, fewer office visits with sublingual, and that may lower the cost, but the tablets are usually more expensive than the subcutaneous product. In the case of subcutaneous, you have to go to office visits that could increase the overall cost, but injections usually covered by insurance. In the adherence, sublingual immunotherapy, daily home use requires a strong patient commitment, and in the case of adherence of subcutaneous, enough schedules can improve adherence. What is best for? So in the case of sublingual immunotherapy, those preferring home treatment or who dislike needles, and in the case of subcutaneous, those who want tailored mixes and don't mind injections. The choice is from the allergist and from the GP that is going to see which will be more beneficial for patients. We are near the end of this clinical case. Let's talk about the take-home messages. First of all, allergic rhinitis in children should be a diagnosis considered by primary care practitioners. There are several treatments for allergic rhinitis that will depend on the type and severity of allergic rhinitis. Nasal steroid administration, technique, and appropriate training is essential for its effectiveness. Allergen immunotherapy is a good option for patients to improve outcomes over those achieved by conventional therapy. And, of course, allergen immunotherapy was the first and only treatment for allergic rhinitis that could modify the disease. If you want to learn more about rhinitis, I would suggest you to read our practical guide to improve rhinitis diagnosis in primary care. The IPCRG group of allergic rhinitis and non-allergic rhinitis created these guidelines so that you can read, look, and understand the basics about rhinitis and to see the differentials. Thank you so much for staying until the end of these clinical cases, and I hope that you enjoy it as much as we did preparing it. Thank you.